Welcome back to Investigator Insights. I'm here with Dr. Cynthia Ma. This is lesson 2, and we're going to discuss the CDK4/6 inhibitors in the second-line treatment setting. Along with promising results of palbociclib, phase 1 data of ABEMACICLIB were presented at the AACR meeting. Can you tell us the details of ABEMACICLIB for pretreated patients with hormone receptor positive, HER2 negative breast cancer?
Yes. This was a phase 1 study, initially started with the dose escalation phase. And in that phase, they determined the maximum tolerated dose of this ABEMACICLIB was 200 milligrams every 12 hours. And the dose-limiting toxicity was also determined in the initial dose escalation phase, which was fatigue. That was grade 3. The data that was presented was from the expansion cohort. So after the dose escalation phase, the trial was expanded into 5 different tumor types in the expansion phase. So the cohort D was the breast cancer cohort. So this is a single-agent trial in this patient population. The eligibility for the cohort D, which is the metastatic breast cancer patients, are they have to have metastatic disease, and they have to have measurable disease. They have to have ceased response to their standard of care of treatment. It's interesting that in that trial, they can continue with their last hormonal therapy if that was the one that they just progressed on. So that was interesting. So this trial enrolled 47 patients in cohort D, the metastatic breast cancer cohort, and 36 of those patients were estrogen receptor positive. So majority of the patients were. And this is really a heavily pre-treated patient population. So the average prior regimen was 7. So that was really heavily pre-treated. The average patient age was 55. In that estrogen receptor positive patient cohort, the response rate was found to be 25%, and the clinical benefit rate was 61.1%, which was pretty high. And in that cohort also, when they look at the progression-free survival, was 9.1 months. And among those 36 patients, at the time of their presentation, they still had 18 patients still ongoing with their treatments. So really, the 9.1 months was an estimate.
Are there other trials testing CDK inhibitors as a second-line treatment?
Yes. So ABEMACICLIB, this drug that we just talked about, is in phase 3 study in combination with fulvestrant as second-line treatment after disease progression on aromatase inhibitors. It's called MONOTHERAPY trial. And also for the palbociclib, the accrual has completed for their phase 3 study. In that trial, they combined fulvestrant with the palbociclib. And this is also a second-line treatment for patients with metastatic disease that's progressed on aromatase inhibitor.
Do you think that CDK4/6 inhibitors can be effective as single-agent therapy in breast cancer?
So based on the data presented for the ABEMACICLIB, I would agree that single-agent CDK4/6 inhibitors can be effective in metastatic estrogen receptor positive patient population.
Do CDK inhibitors have a future application in the second-line treatment setting?
Yes, I agree with that. I think we're still waiting for the results of randomized trials, but I agree this is a very promising drug.
What should clinicians remember about CDK inhibitors in the second-line treatment setting?
We can say that CDK4/6 inhibitors have shown promise either as a single agent or in combinations in the heavily pretreated patients. So in the ongoing trials are evaluating confirm its efficacy in this patient population. There are ongoing trials that the patients can enroll, and so I guess depending on the results of the study, whether they would be approved or not. But so far it seems like they can really improve the response, and also even with single agent, they can induce tumor response. And they are fairly well tolerated. With the ABEMACICLIB, the most common side effects were diarrhea and fatigue. The neutropenia incidence is a little lower than the palbociclib, seems like.
Well, thank you. We appreciate those insights.
Thank you.